Welcome to Dr. T's online lecture. Today, we're going to be learning about Graves' disease, an autoimmune disease that causes hyperthyroidism. Before we can get into the disease, let's have a review on the hormone pathways of the thyroid. It all starts in the brain where the hypothalamus secretes thyrotropin-releasing hormone, or TRH. TRH stimulates the anterior pituitary gland into producing thyroid-stimulating hormones, or TSH. TSH, in turn, stimulates the thyroid into producing thyroid hormones T3 and T4. T3 and T4 goes on to signal the hypothalamus to reduce or inhibit the production of TRH. This is called a negative feedback loop. Let's see that again. Now, how does this relate to Graves' disease? Well, Graves' disease is an autoimmune disorder, meaning that a patient inflicted with it synthesizes antibodies that react with their own cells. The thyroid expresses TSH receptors like normal, but people with Graves have B cells that secrete antibodies that bind and block these receptors. These same B cells can also present the TSH receptor as an antigen to T cells and induce a cell-mediated response through autoreactive T cells. There are three types of autoantibodies produced: stimulating, blocking, and neutral. Stimulating antibodies bind to the TSH receptor, induce cyclic AMP generation, and inhibit TSH-mediated activation. Blocking antibodies prevent TSH from binding to its receptor. And lastly, neutral antibodies do neither of these, instead inducing cell apoptosis. Now, how does all of this cause Graves' disease, which essentially is hyperthyroidism, aka an overreactive thyroid? Let's go back to the hormone cycle. As the autoantibodies bind to the TSH receptors, the thyroid receives the signal to increase the secretion of T3 and T4. T3 and T4 inhibit the production of TRH and TSH. As more and more antibodies bind, the thyroid increases the T3 and T4 secretion rate, which in turn decreases the secretion of TRH and TSH. This cycle continues on until you get a severe reduction in TSH levels and an elevation in T3 and T4 levels. You may be wondering, who are at risk for Graves' disease? Well, here are some statistics. Women between the ages of 40 and 60 have a higher risk of development. Some major risk factors are mainly genetic, but there have been cases of disease development due to smoking and pregnancy. Now on to the symptoms. People with Graves have what is called a goiter, an enlarged thyroid. This enlargement is due to the antibodies signaling the thyroid to be more active and secrete more and more T3 and T4. Many patients also have Graves' ophthalmopathy, with redness and inflammation and possibly bulging of the eyes, due to the antibodies reacting to TSH receptors that can be found in the connective tissues around the eyes. Some undiagnosed symptoms also include anxiety, fatigue, increased appetite, insomnia, and weight loss. Laboratory tests that are normally done to help diagnose a patient would be a hormone panel that measures the levels of TSH and T4 in the blood. Elevated T4 and a decrease in TSH, along with symptoms, are good indicators for Graves' disease. If a patient is diagnosed with the disease, they have three treatment options: antithyroid drugs, radiotherapy, or surgery. Antithyroid drugs are normally the go-to option. They have immunosuppressive effects and decrease T3 and T4 by inhibiting thyroid peroxidase, an enzyme that's needed in the hormone productions. The drugs can be administered for up to 2 years. The next option, radiotherapy, induces a gradual necrosis of the thyroid cells. This loss of functional tissue eventually leads to hypothyroidism. And lastly, the surgical treatment calls for the complete removal of a thyroid. All treatments have their pros and cons, and any possible outcomes should be discussed with your doctor. And now that's all to know on Graves' disease. This is Dr. T signing out.